2020, and we have reason to celebrate today. Anybody know why? Dr. Santiago is here. We're very pleased to have him with us. So we're going to be doing a Deuk Laser Disc Repair, lumbar, L34, L45, left side. Our patient has back pain and left leg pain, and they have a pinched nerve from stenosis. They have a herniated disc, 3-4, L45. And Sean, are you going to do the MRI review?
Yes, we have it up on the screen now. If you look at the two levels that we'll be operating on today, L34, L45, both have disc herniations, neuroforaminal encroachment, which means nerve root encroachment, and spinal stenosis. They also have kyphosis and scoliosis, which shows you that this surgery can be performed even if you have deformities of the spine.
Okay, thank you for sharing. So go ahead and take a look at the screen, and you'll see, keep going the other way, you'll see actually the MRI report, and the MRI report will show you what this patient has. Very common problems: degenerative disc disease, herniated disc, bulging disc, stenosis. But they also have scoliosis and kyphosis, which is deformity of the spine. We're not fixing that today. We don't need to, because they're not causing pain. All right, Dr. Deuk here. Are you awake? We're going to get started, okay? 3, 4, 4, 5, left side. We're all in agreement. All right, I'm going to give you some numbing medicine, okay? You're going to feel a little bit of burning in the back here, but that's normal. That's just the medicine going in, so don't be upset. Okay? If at any time you feel a lot of pain, say ouch, and I'll give you some medicine, but don't try to get up off the table. All right. This is just my fingers pinching around a little bit, okay? All right. Now, are you able to see the x-ray view yet, Sean? We have an x-ray image up.
Yes, I can.
All right. Go ahead and show the audience the x-ray image. So you can see from this x-ray image, this is called an AP view, anterior posterior, front to back. You can see that we're looking at the about L3 to S1. You can see there's a lot of twisting of the spine, collapsed degenerated discs, stenosis, needle down, 6 cc's injected. And so there's a lot going on structurally, but most of it is not important. The only thing that's important is actually something you can't see, and that is a tear in the back of the disc. You can't see it on x-ray. All right, I'm going to get started. Remember, if you have pain, just let me know by saying ouch, okay? All righty. Shot? Let's go ahead and do a lateral. Let's see where we are. The lateral view is the best view to identify what disc we are at, and it's the best view to navigate to the foramen. The AP view is also necessary, so we're high. We need to get a little bit lower. No problem. Let's have that local again for the skin, the numbing medicine. Do you feel this going in? You feel anything there? No? Yes? All right. Are you comfortable? Without the x-ray picture, it's impossible for me to know where we are in the spine. So I use the x-ray image to guide my treatment. Without it, the surgery would be impossible. Shot. We've talked before about x-ray images. So, Jordan, we're focused on 4-5 first. You can see there's a little listhesis, antral listhesis at L4-5. That's our first target. So I think you're pretty good. I think we could see a double shadow of the pedicle just a little bit. So maybe you can do a little wagging. Shot. All right. It's not too bad. Still a double shadow on the pedicle. Maybe we can try a different wag. Are you comfortable, ma'am? Shot. I think that got worse. Yeah, we go the other way. Yeah, that's actually pretty good. But you're really far south, and I don't want you to be that far south. So let's move everything north. For probably further north, maybe. Let's see where you are. Yeah, you're still too far south. Shot. All right, that's better. But let's see if we can wag it back into view. Because you're off once again. I don't know, it doesn't look right to me. Let's see what we can do. Wag it some more. Yeah, a little bit of that, but I don't think that's the biggest problem. I think it's more wag still. That's really good. The pedicle's lined up nicely. I think that's probably as good as we're going to get. But again, why are we seeing so much below the sacrum? We shouldn't be seeing all that soft tissue. Right? It's very odd that we're seeing so much soft tissue. So what we're dealing with is the scoliosis, folks. And because her spine is curved, it's creating not a challenge, but yeah, I guess it is a challenge with respect not to the surgery, but with respect to getting the x-ray in the proper position. So, shot. We will get there. It's just a matter of perseverance and adjustment and time. You can see we're targeting the, is that uncomfortable? Huh? How does Dr. Santiago do it? I don't understand. Shot? Sure. Shot? Oh, I feel a big herniation there. Shot? Question is can we get into the disc space? Let's get an AP view. I'm on the herniation. I'm literally pushing on it. Now you can't see the herniation, but it's right at the tip of the needle. The needle is in the foramen at L4-5 at the left side, left foramen. I know you can't tell that based on the lateral view. Let's get an AP view. Perfect, absolutely perfect positioning. Now you can see the tip of the needle is in the mid-pedicular line. Go back to a lateral, please. So I'm hitting something, right? But you're not seeing it on the x-ray. Why? Because x-rays really are better for seeing bone, hard things like bone or foreign bodies. And you can't see herniations on an x-ray unless they're really calcified. And so I'm actually hitting the herniation right now with the tip of the needle. So, and it feels like a herniation to me. The problem is I'm not entirely happy with my trajectory, but I'm going to give it a go and see what happens. We know she's got a lot of arthritis. Shot? It looks like it wants to behave. Whether it behaves or not, we'll see. I had a feeling it was going to be a misbehaving disc or trajectory, however you want to call it. Yeah. Well, it's the, I like the approach from the standpoint of being able to access L3-4, which is the next disc, but shot. We're there, It's just a matter of whether I can finesse this to its final position. And that's where, as Dr. Santiago mentioned, that's where the bone spurs are playing their role in blocking me. We're awfully close though. And I can feel she's pretty relaxed, so you're not having any pain? No? All right, I'm going to give us just a little bit, just another minute here to finesse in. But I feel that we're in an area that it's safe to proceed. We're just not going to get a very good discogram. Well, all right, not too bad. I just don't know why it's not going. I like it to just do what I want it to do, of course, as we all do, but shot. That's pretty good. Let's get an AP, just verify. So for those of you who aren't sure, if you look at the bone, the square below the needle, that's L5 vertebral body. And then there's a gap, which is the L5S1 disc. Yeah, actually it's not too bad. All right, fine. We'll take it. Are you comfortable? Just stay where you are. All right, now it's time for our incision. We make a 7mm incision. So for those of you wondering, is this percutaneous? The answer is no. Percutaneous procedures, there's no incision made ever. Otherwise it wouldn't be percutaneous. Percutaneous means through the skin with a needle. Up to this point, it was percutaneous, but now it becomes a real surgery. And I don't mean percutaneous. Procedures are not real surgeries, but they're not. That's why they're called procedures. They're needle-based procedures, not real surgeries. But, you know, there's no real strict definition. So some people will call percutaneous procedures surgeries, other people won't. All right. In the strictest sense, they're not. Shot? And they're actually not done by surgeons. Are you awake? Shot. All right, so on the AP, we're close to where we need to be, but let's see where we are on the lateral. I suspect we're not going to be where we need to be on the lateral view. We're going to have to make an adjustment. I think I'm too posterior. Yep, too posterior. Which is, it's always better to be too posterior than too anterior. Too posterior is safe. Too anterior is not good. And we're not too anterior. Everything's going really well. I'm just muttering and mumbling to our audience that's watching, okay? That's what I do when they don't ask me questions, Shot. I just mumble and mutter until somebody asks me a question, and then I become intelligible. Shot. So we're aiming for 3-4 now. And I'm feeling a lot of arthritis here, a lot. And that's the degenerative disease of the spine. Shot? So people ask me, does this surgery work for degenerative disease? The answer is yes. Shot? Yeah, she probably did. We're right where that second herniation is. AP. So this patient has degenerative disc disease, and on a scale of 1 to 10, it's probably an 8 structurally, an 8. That looks good. Lateral. I've seen slightly worse. Maybe she's a 9. I've seen slightly worse, but she's really bad. We're not here to fix degenerative disc disease. We're not here to fix the spine and make it look really non-degenerated. Our goal is not to eliminate degenerative disc disease. Our goal is not even to fix the scoliosis or the kyphosis she has. Our goal is to get rid of her pain. Right? That's what you want. You want your pain gone. Sean? So, the Deuk Laser Disc Repair procedure cures pain by targeting the source of the pain. And the source of the pain is the disc. It is the tear in the back of the disc, right against the superior end plate. Again, close, but no cigar. Sean? Where do you feel that, Sean?
Where do you feel that pain? But where? Is it still in the back or going down your leg? On the back.
Sean?
Okay.
All right, we're almost done. We're just coming up against your herniation, and it's a big one. Sean? Once again, and the bone spur is really deflecting me. Sean? You know, we need to see that disc space better. Let's move the fluoro north. More. And let's get a shot. All right. So let's line up that pedicle a little bit better. It's not horrible. And I think Dr. Santiago's suggestion of a little bit of rotation this way may be in need, but no more than a degree or two. Shot, let's see where we are. It seems to be better. I believe that is better. That is better. Okay, so you can see that I'm low in the foramen. You can see the facet joint is massive. And you can see that we need to be a little bit higher. So that's why having the right view on the fluoro is so important. Now, for those of you who do this kind of spine work and you use a fluoroscope during your procedure, Shot, you know how important the quality of a good fluoroscope is. Shot? And I will tell you, folks, that there are many different fluoroscopes out there to buy. Where do you feel it? Where? Okay, thank you. Now? Better?
The what?
I can't hear her.
No, I'm having the pain right now.
All right, good.
Going down the leg. Not going down the
Yeah,
leg.
you're fine. You're fine. Remember, we're working around that pinched nerve, so you're going to, once in a while, you might feel something. Don't be alarmed. We're correcting it, so you won't feel it. Shot? I feel a lot better about this trajectory here. Shot? And I'm feeling that same problem, the herniation once again, but this is a better trajectory. The problem is she's so collapsed. Shot? Let's see a little more wag. I think we're missing something here. The pedicles of the bottom vertebrae are not lined up properly. Let's see if we can line them up. Nope. Other way, I think. Why is it important to line the pedicles of the bottom vertebrae up? Because that's really the surface you're using to orient the position of the needle. That's better. So you can see now I'm actually hitting a bone spur off the superior end plate. So I'm dancing around the foramen, and I am getting closer to our goal shot, but not quite there. Shot. Shot. Shot.
We have a question.
Yes.
One of our viewers is wondering, do you need to be a neurosurgeon to do this kind of procedure, or can an orthopedic surgeon do it too?
Oh, it's a good question. Do you need to be a neurosurgeon to do this kind of procedure, or can an orthopedic surgeon do it too? The answer is a well-trained orthopedic surgeon could do it. And for those of you who have listened to me broadcast in the past, I don't believe the title neurosurgeon or orthopedic surgeon empowers the doctor with any great potential skill. It really comes up to the individual as a person. Do they want to do this type of surgery? Are they good? Are they cautious? Are they detail oriented? You know, are they capable? Do they have the physical, mental ability to do this type of surgery? That's more important than titles of neurosurgeon or orthopedic surgeon. So I think if you have a really good orthopedic spine surgeon who really understands the anatomy of the spine quite well, and believe it or not, it's not something that every surgeon has, is a commanding knowledge of the anatomy. But the anatomy, understanding the anatomy is extremely important to be a successful surgeon in general. And then of course you have to want to do a good job. So there has to be a desire to do exceptional things for your patients. Shot? I mean, those are more important traits, individual traits, more important than a title of neurosurgeon or orthopedic surgeon. I've seen a lot of really bad neurosurgeons that are technically bad. They would never be able to do this kind of surgery. And I've seen, let's get an AP. I've seen some very good orthopedic surgeons, not many, but a few that are really, really good. So we have to stop thinking about it as being orthopedic or neurosurgeon, or even neurosurgeon versus neurosurgeon. We need to think more about it being, is this doctor capable of doing the job right? All right, so we are close to the midline, but we are rotated. Let's go back to the lateral view. Well, we're definitely getting into the disc, but I'm not entirely happy with where we are. Question is this the best we can do given the anatomy? I feel I can reach this place again if I needed to. So I'm gonna come out, shot, and see if I can't do a better job. So this is where it doesn't matter if you're a neurosurgeon or an orthopedic surgeon. What matters is if you understand the three-dimensional anatomy. Do you understand what I'm saying? That's what matters. And that really depends on the person rather than their training. I'm going in, shot. Definitely getting in there. I'm just probably not gonna be able to get a good discogram here because I'm not really in the disc as well as I'd like it to be. I'm feeling here, bone spur, shot. It's gotta be the end plate. Are you feeling anything? Shot.
Pressure. Nothing going down.
Pressure.
Yes, pressure, nothing going down. Okay. So your adjustment there was more lateral, right?
Yeah.
Instead of going more medial.
You're correct. Dr. Santiago is an anesthesiologist. He's been trained here at Duke Spine Institute to do interventional pain management. And I would trust him to do this procedure on a patient or me more than I would trust 90% of neurosurgeons and 99% of orthopedic surgeons because of who he is. It has nothing to do with the fact he's an anesthesiologist. Some anesthesiologists do pain management. He's one of them. But it's his attention to detail, his compassion, his caring, his desire to do things right. That's what makes him great. It's not where he was born, his name. It's nothing to do with anything other than the person, in my opinion. Shot. So, yes, an orthopedic can learn. I think we're fine, you know. I've been here before. Are you awake? I just have a hard time getting in where I want it to be into the disc, but once we're past the annular tear, we're safe, and we're in a safe place to proceed. But I'm just not going to, oh, there we go. There we go. Yeah, now we finally get it. So sometimes the patient loosens up a little bit, like their back relaxes. Remember, the muscles back here in the patient's back, what is one of the bigger causes of back pain? Muscle spasms. Why do muscle spasms? They spasm because of what we call instability. So there's something in the spine, a disc problem, a facet problem, it causes pain. That pain suddenly causes everything to tighten up, and they get a spasm. So what's important during this procedure is that the patient is comfortable, not feeling pain, and then the muscles relax. And when they relax, I can do my surgery easier because there's not this compression of the bones together squeezing the disc space down, locking the disc space down. I won't be able to get my needle in there. Are you comfortable? All right, so I was patient. I took my time. A lot of surgeons are not so patient. Okay, it doesn't matter if they're an orthopedic surgeon, a neurosurgeon, they're just not patient. They don't wait for that right moment. And sometimes, as you could see, that window of opportunity to have this thing put in perfectly depends on time, but it also depends on location. And so I moved the needle around patiently, and I got to where I wanted to be. Are you comfortable? That has nothing to do with your title, Shot, of neurosurgeon versus orthopedic surgeon. That has more to do with the person you are. Are you patient? Did that hurt? How bad on a scale of 1 to 10? A 10. Is that your place where you typically get back pain? Yeah? All right, so we have concordant pain, 10 out of 10 at L3-4, which is good. It's a really good sign. So we just tested that disc that I'm in, and we got a beautiful discogram. You can see the disc is now filled with a dye. It's black on the x-ray. And the patient experienced 10 out of 10 pain that she normally gets every day. So I know for sure once I fix this disc, that pain will be gone because we're going to use the laser to repair the tear in the back of the disc, and that's what makes the Deuk Laser Disc Repair the Deuk Laser Disc Repair. It's a unique procedure where I repair the tear that causes the pain that she just felt. Now the dye itself causes an activation of the nerve fibers that are along the tear, typically causing pain. Are you comfortable? Having a lot of there's better. Anything there? All right, pressure. So for this disc, she didn't really get pain, she got pressure. But this disc is causing the most narrowing and pinching, physical pinching of nerve. So we have a herniated disc with a herniation that's hitting the nerve, causing her leg symptoms, but not so much of the back pain. So I'd say most of her back pain is coming from L3-4, but L4-5 is causing most of her leg symptoms. All right, you're going to go to sleep. When you wake up, we'll be done. Can you count from 1 to 100 for me, please, out loud? Keep going. Shot. All right, so the guide wire, I'm starting at L45, and I'm getting the guide wire in to the disc, down the needle, and I really want to see the end of the guide wire before I take this needle out. Shot. And I haven't seen it yet. So there may just be some bone spur down here, and there is. I can feel it with the needle, with the guide wire. Shot. I literally feel it, and that's probably as good as I'm going to get. So I'm going to back the needle out, and I'm going to look for my guide wire tip as I do that to make sure it's in the disc and it stays there while I back the needle out. Sometimes the needle will grab the guide wire. Shot. There it is. You can see the needle still going in the foramen, and then now the tip of the needle is right at the back of the disc, but the guide wire is inside the disc. Sometimes the needle will grab the guide wire because the tip of it may be bent a little bit, or you may get some soft tissue wedged in there, and it'll actually, when I pull the needle out, it'll pull the guide wire out. So you don't want to do that. So I hold the guide wire in position as I bring the needle out, and of course constantly checking. Shot. Now, why would the needle be bent? Well, the needle would be bent because I have to apply force to the needle to get it past all these hard bone spurs. And this is a perfect example of that right here. Can you all see this?
Yes, we can.
Can you see that the needle is bent?
Yes.
Yeah, so it bent a little bit while I was trying to get it in. Now, the reason why I had to apply more force to get the needle in the disc is because her discs are completely collapsed, so they're actually resisting the needle going in. Plus there's bone spurs that are pushing against the needle, trying to keep it from coming in. Basically, the disease is fighting me and doesn't want me to gain access to the disc to repair it. Okay? You can see everything is being done with a 7mm incision. I'm going to bring the dilator down. It looks like a big metal pencil along the guide wire. And this dilator is going to spread the tissues. It will not damage the tissues. It will spread them. Spread them means just separate them without hurting them. Shot. So the tip is right at the facet joint. I'm going to go past the facet now into the foramen. Shot. Now I'm feeling the herniation right now with the tip of this metal pencil called the dilator. I feel the herniation right there. I'm pushing against it. It's hard. And that's the herniation that's pushing on the nerve root. So I'm going to do something that might surprise a few of you. I'm going to use a good old-fashioned hammer. Okay? I didn't buy this at the Home Depot. Nope. Instead, I paid about 1,000 times what a normal hammer would cost so I could have a special surgical hammer. But this hammer is going to be used to advance the dilator into the disc space. Shot. And I'm going to do that using the X-ray to guide me. At this very moment that I'm pushing the disc herniation into the disc space, as I advance the dilator. Shot. Now it's important the patient's relaxed right now, which she is. She's perfect. Because if she's not relaxed, she's going to be tightening her back up, and that's going to make it even harder for me to get this dilator in. You see? Shot. But the more relaxed she is, the easier it is for me to get the dilator in. All right, just let me check something here, because the guide wire is coming out the back end, which is fine. Shot. But let's see if I can advance this now without the guide wire, because I'm going to start trapping the guide wire, which I don't want to do. Shot. And this is where your experience comes in. You have to visualize and feel that you're doing the right thing. Now, if you don't do this right, you could fracture the bone. You could end up in places you don't want to be. Places that could cause serious harm to the patient. So having experienced hands that I can feel. It looks like I'm making a barbaric move, but I can actually feel every millimeter that that dilator moves through her body. I can feel the bones separating. I can feel the disc giving way. I can feel all of it happening. I can see it happening in my mind too, and I see it on the x-ray to affirm what I'm feeling. That's what a good surgeon does, okay? And it doesn't matter if you're a neurosurgeon or an orthopedic surgeon. It matters if you pay attention and you can feel that change. You hear about people talking about dinosaurs, right? That their primary vision wasn't great, but that what they were good at perceiving was change. The change, of course, is movement of their prey, or whatever it is in their visual field. It's the perception of change, the perception of movement that made them great. Well, a good surgeon can feel change. That's all I can tell you, Shot. And there's lots of bad ones out there. You see, doctors aren't selected to be surgeons because they could feel change. They're selected to be surgeons because their grades are good. Unfortunately, the training and the selection process for surgery is not always the right selection process, but it's gotten us where we are today, right? But I'm a bit more picky about who I work with. And I wouldn't train someone that I didn't believe had the ability to do the job really well. I actually started training Dr. Patel to do this procedure because I believe Dr. Patel can do it. And he can do it safer and better than any surgeon. And if Dr. Santiago joined me, I would probably train him as well. That's because I believe in his ability to do a great job. So once again, more important than neurosurgeon versus orthopedic surgeon is it's the person. Right? Everyone knows the story of the 300, right? 300 soldiers that fought off a Persian army of 1 million soldiers. Maybe it was 10,000. Point is, it was overwhelming odds. If you say who's going to win, the bigger army with more soldiers or the smaller army with less? Most people would say, of course, the bigger army, bigger numbers, bigger army. But those 300 fought and were able to hold off for, I don't know how long it was. So once again, it's not the fact that you're a soldier, but it's how you fight that matters. It's not the fact you're a surgeon, but how you operate that matters. How you care for your patients, that's what matters. It doesn't matter where you trained. It doesn't matter what you look like. It matters what you do and how you do it. All right, any other questions? So we're inside this disc, and this is the tear and part of the herniation right here. So I'm going to use the laser to remove it. Unfortunately, I can already tell you this is going to be a little bit bloodier of a case from the standpoint of there being more bleeding, which makes your view through the endoscope, and mine, by the way, worse. Okay, so if you look, it's kind of hazy. The haziness, reddish haze you're seeing is blood. And it's coming from the end plate right over there to the left. Okay, you see it coming there? So I can't do anything about that. I can't improve your view. I'm sorry, but the reality is I've done this enough so I'm able to know what I need to do even when the view is not so great. It's kind of like a pilot who knows how to fly a jet. Even when they can't see with their eyes that well, they know the landmarks. Or maybe they use a computer or instrument flying. The point is that I know I can work around the bleeding, even though it would be very difficult. If this was my first case ever doing, it would be very concerning and I probably wouldn't do as good of a job. But since I've had this problem before, I know how to deal with it. And I'll show you some of the tricks as we go along for dealing with the bleeding. But the most important, standby laser, is to try to avoid it. Try to avoid it. So don't injure the bone. Now, we are removing some bone spurs, so inevitably there's going to be some bleeding as you remove bone spurs, because bone spurs are basically outgrowths of bone, and the center of the bone spur many times has bone marrow inside it, and they bleed. Even though they're just bone spurs, they'll bleed as you remove them. All right, so there's the tear, once again, the blue thing, and we're getting our scope and tube in position to get rid of this tear, and the best way to do that is with a laser. The laser I use is a holmium YAG laser. It's a medical laser. It's a $100,000 machine, and it's, in my opinion, the best laser available right now to do this job. There are other lasers that are cheaper. There are other lasers, other types of lasers, like CO2 lasers, for example, but they don't do this properly. So I use only a holmium YAG laser. The golden color you're seeing at the tip of the laser fiber is calcium, basically calcified scar tissue, meaning this is a long-standing problem. You don't get calcified scar tissue unless you have scar tissue for years and years and years, and inflammation is ongoing for years. It's called dystrophic calcification, DYSTROPHIC. And dystrophic calcification is basically calcification by your body of abnormal structures, abnormal tissue that's been damaged or injured. The calcification is not the problem. I'm just mentioning it just for interest, so you can understand what's happening. For those of you who don't know, the blue line that you're seeing at 12 o'clock is the laser fiber. It brings the laser energy from a machine which is about the size of a washing machine. It's at the foot of the bed, the patient's bed, and that machine is plugged into the wall, and it's I think it's on a 220 circuit, right? It's on a 220 circuit. Everything else is 110, but that machine is 220. It's a very powerful machine. And it basically creates a burst of energy that's transmitted along this fiber all the way down into the disc where I direct it. That's a bone spur right there. That's weird. Did we just change suction? How are we doing on irrigation, Gary? Sean, any questions from our audience?
None currently.
These are all bone spurs I'm removing, by the way, in case you're wondering. For those of you who've watched more of these surgeries, you'll note that this disc looks different, right? This disc does not look like some of the other discs that I've operated on, because there is more bone spur here. And this is more of a degenerative disc, like more advanced degeneration rather than a herniation. Okay? There's some fat in the epidural space. We are right at the neuroforamen entrance, outside the disc, just outside the disc. This is all bone spur. And I'm not going to ever be able to remove all the bone spurs with any surgery. There's no surgery in the world that can remove all the bone spurs. That's not our goal. Our goal is to make this patient pain-free and restore her leg function on the left side. That's our goal. To do that, I need to unpinch the nerve, and I need to repair the annular tear, basically. Get rid of the tear and the inflammation in the tear. All right. I should be able to show you her nerve in just a minute when I'm done. So what's the message with this surgery? The message is, even if your spine has degenerative disc disease, it can be fixed with Deuk Laser Disc Repair. Even if your spine has scoliosis, kyphosis, most likely it can be fixed with Deuk Laser Disc Repair 99% of the time. Because your pain is not coming from the scoliosis or kyphosis, it's coming from the disc, from the tear in the disc that's led to the scoliosis and kyphosis. Okay? So that would be like if you say, well, what about treating the scoliosis and kyphosis? It would be like treating the smoke from a fire. If you only treat the smoke, you still have the fire to deal with. It's going to keep burning and making more smoke. You have to put the fire out to get rid of the smoke. So if your efforts are focused on just fixing the smoke, you're never going to put the fire out. You're going to keep getting smoke. Doesn't matter how good you are at removing smoke, you're going to keep getting smoke. Because the fire, the primary cause, is not dealt with properly. If you don't fix the tear in the disc, you're going to continue to have pain. That's why most back surgeries fail. Most back surgeries fail because the surgeon doesn't know that. The surgeon was never taught that. The surgeon never read my paper. They don't understand that the tear in the back of the disc is the cause of back pain. So to successfully treat back pain, you have to successfully treat the tear. All right, we've gotten rid of a lot of the bone spur. At 12 o'clock is looking at the next nerve. There's the nerve root right there. You see the white thing? So we're just underneath it. A little bit of bleeding from epidural vein and bone spur. So one of my tricks, if I really need to see well, is I'll take the laser out, and if I just want a brief glimpse of what am I doing in here, I'll put my grabber down. This is very strange. Is that the right grabber?
Yes, sir. Yeah. You just use it.
Huh? I know, but I can't get it down. Is there some disc in the end? Feels fine. There we go. I think there was just some bone in there. So look what happens when I put the grabber down. It actually stops the bleeding. Isn't that amazing? So I can get a good view, what I need to work on, and then I take the grabber out and it starts up. And the reason for that is it creates back pressure and the fluid coming out. Whereas if you don't have the back pressure, the irrigation just keeps pulling the blood out. Anyway, it's a little trick I've just showed you. You won't need it if you do this surgery very often, but if you have a lot of bone spurs, you will eventually need it. The more degenerated the disc, the more it bleeds. That's just the way it is. All right, going to be done in about 10 seconds here. I'm going to look around a little bit more just to make sure I got everything that we can get. By the way, if you want to learn this technique, you can come and learn it from me. I'll teach. However, if you try to do my technique without training, do not expect me to save your neck when you get sued for a complication, because I won't. You have to have proper training. And proper training does not necessarily mean watching my videos here. That would be kind of like watching a jet fighter fly a jet in battle, and then you think you could fly a jet. No. It doesn't work that way, right? That's the way crazy people think. So there's a right way to learn how to do things, and you have to go through the process. I had to learn how to be a neurosurgeon. It took 7 years of training, 7 years of my life. Literally 110 hours a week was the average amount of time I worked on my feet. Sometimes I did 120 hours in a week. Awake, running around, taking care of patients, operating, seeing emergency consults. The point is, you got to put your time in if you want to be able to do things like this type of surgery. Laser off. You got to invest your time, your effort, your brain power into training yourself and learning. Okay? I make these surgeries look easy, but they're not easy. Yes. Yeah, switch irrigation. Thank you. All right. I make them look easy because there's a very narrow path to walk as a surgeon when you're doing these surgeries, and I walk that path every time. And I make that walking that path look easy. It's like people climbing Mount Everest. If you watch their GoPro video, you say, that's not so hard, right? It looks easy. You just, why are those people struggling? Why do people die? I don't get it. It's easy, right? Sunny day, and there's a path, and there's wires that you can hold on to. You got to train for it. You got to make sure you watch the weather. You got to get lucky that the weather is just perfect. You have to be prepared with all your supplies. Let's go lateral, please. All right, so we finished the L45 disc, and now we're going to go to the L34. Remember, the 3-4 was the one that's causing her back pain, and the L45 was causing the leg pain. I think 3-4 will also be contributing to the leg symptoms as well. So when people send me their MRIs to review, what I'm looking for is I'm looking for the cause of their symptom. I'm looking for, well, what's causing their back pain? What's causing their leg symptoms? Is it the same thing or is it different? And sometimes one disc will be causing the back pain and the other disc will be causing the leg pain, or neck pain and arm pain. All right, shot. Okay. Not too bad. The fluoro can drop to the floor anymore or no? All right, it's fine. It should be fine. Let's try to wag that in a little better. Especially the L4 pedicles. They don't look so good. For those of you who have been watching, have you noticed how little blood loss we've had? We've lost probably about 3 milliliters of blood. 3 ml. There's nothing. If you cut your finger, you're going to lose 3 ml of blood. So we've lost essentially the equivalent of a finger cut with this surgery. Shot? All right. So I've got the guide wire in position. I'm going to remove the needle. And I'm going to keep the guide wire where it belongs, in the disc. The guide wire will guide the dilator. The needle that I placed earlier is the pathfinder. The guide wire is merely a guide left behind by the pathfinder. My gosh, Dr. Santiago, how do you do such a good job with the anesthesia? I don't understand.
It's watching your steps what makes a difference.
Yeah. Well,
Anticipation.
perfect patient control and safety. Again, Dr. Santiago makes it look easy too, but it's not not easy. How many anesthesiologists have I gone through? Right? How many? God, this year. Too many to count. They all think they can do anesthesia, but they can't. So once again, I'm using the mallet to gently advance the dilator tip through the foramen into the herniation. And I have a feeling this disc is going to be more reactive for her. Don't you think? Because we know it's more painful. I think I'm in a position I could take the guide wire out right here. The reason you want to get the guide wire out at some point is otherwise you'll trap it with the tip. You got metal to metal shot. And the problem is that the tip of the dilator will literally bend the guide wire and pinch it. And then you won't be able to get the guide wire out. Then you have the risk of breaking the guide wire in the disc space, which is not something you really want to do, period. I mean, it's bad. Then you have to do an open surgery to get it out if you want to get it out. Fortunately, I've never been in that situation. And we're very careful. Luis inspects every guide wire to make sure it's got structural integrity before we even use it. We throw away guide wires that are damaged. But that being said, it's something that you have to really take careful consideration while you're doing the surgery, not to pinch the guide wire. Is that the latest? All right. Shot. Let's see where we are. Perfect. All right. Any questions from our audience? Let's get the fluoro out. This will be our last disc we're doing on this patient. We don't have anything else we're doing, right? So the next patient is going to be a 3-level. The next patient is a nurse. She flew down from Chicago to have her surgery today. She had Deuk Laser Disc Repair done on her neck. Yeah, Dr. Santiago was involved. That was a couple of years ago, a year and a half ago. And now her back is bothering her. She didn't want any surgeon up in Chicago to touch her. She wanted Dr. Deukmedjian and the Deuk Spine Institute. That's the kind of trust our patients have in us. And so she'll be next, and we're going to be doing 3 discs. Plus, we're going to do some other fun stuff. But she's going to be going back to Chicago. We want her to go back without pain.
We have a question.
Yeah, so we're inside the disc. This is 3-4. This was the one that had 10 out of 10 back pain. So you can see it's a not as old and degenerated or collapse of a disc. There's a piece of herniation right there I just took out. Give me a second, I'll get to your question. There's another piece of herniation right there. Yes, I'll take the question. Save those little pieces. I want to show our audience. Go ahead, Sean.
One of our viewers is wondering, what are the levels you operate on most, and why are those the ones that herniate the most often?
Yeah, great question. Oh my gosh, thank you for asking. What an intelligent question. So one of our viewers, I guess we don't have a name, or where are they asking the question from? Is it Facebook, Periscope?
Through Periscope.
Through Periscope, okay. So one of our viewers on Periscope is asking, Dr. Deuk, what are the levels that you operate on the most, and why is that? Why are those the most affected? I believe that's the question, so that's what I'll answer. The levels we operate on the most in the lower back for back pain are L45, L5S1, and then L34 in that order. L45, L5S1, L34, and then L23. About 75% of the time we're operating on L45. Probably about 65% of the time we're operating on L5S1. And then about 50% of the time, maybe a little bit less than 50, I would say 40% of the time we're operating on L34. And maybe 10% of the time we operate on L23. So that's the order. Now, why is it that way? That is a great question, and it has to do with biomechanics, I believe, of the spine, where the forces pass through the disc. So the forces that pass through the spine and the lumbar spine, they don't pass through equally all discs the same. They pass through the discs in different locations. And that's because of the curvature of the spine. The curvature of the spine, because the spine is curved, means that the force, which is a straight line, by the way, the forces, which are straight lines, generally, those forces pass through a curved area. So, obviously, if the straight line starts in at the base of your skull at a fixed point, at C2, is where we measure from, and it passes straight down to the ground, okay, and it's 90 degree angle to the floor, then you can imagine that that force vector is going to pass through the different discs in the lower back at different places because of the curvature of the spine. So it is the curvature of the spine that determines where the force of the weight of the body passes through the spine. And disc injuries, like the ones we fixed, always have an injury from a force being applied to the disc. Always. 100% of the time. When you have a herniated disc, when you have a bulging disc, when you have a degenerated disc, it's always a result of an injury to the disc. And the injury is always to the annulus fibrosus. Despite what other surgeons have published about injuries to the end plates, I don't believe it. It's garbage. I'm sorry, but I don't know what their motivation for publishing things like that would be, but it's such a stretch, and it's so far from the reality of the world. The reality is that every single disc herniation I've ever seen in my 22 years, and I'm talking 100,000 plus disc herniations, every single one of them has been through because of a tear in the annulus fibrosus. That's the containment membrane that holds the jelly, the nucleus, into the center of the disc. It's always an annular tear. And it's the annular tear that's the cause of the back pain, and most commonly the cause of the leg pain, leg symptoms. Far more is it the annular tear causing the symptoms in the legs, far more often than it is compression of the nerve root by a herniated disc or a bone spur. This is a bone spur. You see I'm about to free it up. There it goes. That bone spur was pinching the nerve in the foramen. We shoved it into the disc when I hammered that dilator in. Okay? So my point is this. All disc injuries, including herniations, bulges, degeneration, slippage of one bone on another, whether it's lateral listhesis, antral listhesis, retral listhesis, scoliosis, kyphosis, all problems with the spine, in my opinion, come from a disc injury. Okay? And that disc injury is an annular tear. And that is what this surgery repairs. And no other surgery in the world repairs it. And the reason for that is I'm the first person to discover that an annular tear is the cause of patient's symptoms of pain. So, of course, if I discovered it, then I'd have to be the first one to tell you. And that's what I did. I did it in my publication in 2012 in Surgical Neurology International, where we described the Deuk Laser Disc Repair, the technique, And then we published a second paper in 2013 about the safety and effectiveness of this procedure for treating herniated and bulging discs. So in those papers, you'll see the annular tear is the primary part of the surgery. And once again, no other surgery addresses the annular tear. Now, fusions do indirectly because you're fusing the disc, you stop movement. So a fusion could potentially stop the pain from an annular tear if it's done right. But you have to treat all the levels that are symptomatic, and most surgeons don't do that. They only pick one level to fuse when there may be 2 or 3. So a lot of patients don't get the full benefit of the fusion because they only had one level fused. So if you have 2 painful discs with 2 annular tears, L45, L5S1, and you fuse one of those discs, you're still going to have pain from the other one. So patients are going to say it didn't work. Of course it worked, but it didn't completely work because you didn't do every disc that needed to be fixed. And that's one of the things that Deuk Spine Institute does is we know ahead of time which discs need to be fixed, and we fix all of them during the surgery. That's why we're so successful. We don't just pick one out of the 2 that are painful, we do both. Or 3 if you need 3, as in the next case is 3. So to answer your question, the incidence, which is the occurrence of painful disc herniations, is determined primarily by the biomechanics of the spine. Okay, biomechanics means the way that forces are transmitted through different discs, different areas of the spine, the way the spine moves, the way it's shaped. So the biomechanics of the spine determine the incidences of individual disc injury. And it doesn't matter whether you live in India, China, Japan, United States, South America. We're so similar with our shape of our spines and the biomechanics and how they move through the spine with those forces that the incidence is pretty much the same wherever you are in the world. So L4-5 is the most common disc to be injured that causes symptoms. L5S1 is second, L3-4 is third, and L2-3 is fourth. Now, let's say that somebody has an injury at L2-3, right? What's the chance that they're going to have symptoms? And I want you to understand the difference. The incidence of injury at L2-3 may be the same as the incidence of injury at L4-5, but most of the L2-3 disc injuries are not symptomatic. They don't cause pain. And that's because of the way the forces are transmitted through the disc. So the incidence of injury and the incidence of symptomatology from the injury, meaning patients that have symptoms from an injury, are different. And they're different because of the biomechanics of the spine, the way that forces are transmitted through those discs. So L4-5 is the most common disc, not necessarily to be injured, but to be symptomatic from an injury and need treatment. Therefore, L4-5 is the most commonly operated on disc around the world. It doesn't matter what country you go to, it's the same. If you read a paper from spine surgery in Japan, the incidence of disc surgery is the same. That L4-5 is the highest. The United States, L4-5 is the highest. Russia, L4-5 is the highest. And that's because of the biomechanics, okay? Yeah. Go ahead. Yeah. Thanks. And just so you all know, all those disc injuries can be treated with this laser surgery rather than any other surgery. And this is the most effective treatment in the world available. That's why I do it, by the way. For those of you who don't know me, I am one of the most well-trained surgeons, neurosurgeons in the United States. Why is that? Well, the training that you get as a neurosurgeon depends on where you go for your training. And there's 120 training programs in neurosurgery in the United States. There were closer to 100 when I was applying, but there's a few more now. So back in 1996, when I applied for neurosurgery training after medical school in Los Angeles, I wanted to go to the very best training program in the country. And I was the valedictorian of my class, and I was a published researcher, and I had a lot of other attributes that made me a very good candidate. So I was one of the top 3 applicants the year that I applied in the United States. So I had Harvard, Hopkins, Columbia, all these very big names that were recruiting me heavily to come to their neurosurgery program. I had the choice to go to where I wanted to go. My choice was to go to the best training. And the best training at the time was University of Florida in Gainesville for neurosurgery. And the reason for that, once again, was not anything other than the faculty. The faculty and also the referrals that they would get from the entire state of Florida. They would get all the most difficult surgeries sent to them. And so I had the ability to take on the most difficult neurosurgical cases in my training for 7 years with the very best faculty. So I saw the latest, best techniques, and I learned them all. So I was fortunate to get really good training. But not everybody has that training. They only take 2 doctors a year, 2 graduates from medical school from around the world. They take 2 people. Each program takes 2. So I was selected along with my co-resident, Paul Tolentino, who was a Harvard graduate, Harvard undergrad, Harvard Medical School, straight A, 4.0, genius. They took the 2 of us and trained us for 7 years. Paul is still practicing. I think he's in Corpus Christi or something like that in Texas. But long story short, the training that you get is very important to being able to do good surgery and good treatment of patients. And it's not the same. It's not the same at every training program. Every training program has very different experiences. I did not learn endoscopic surgery in my training program. This type of surgery is new, and it wasn't. I have to say that what I'm doing today on the lumbar spine was not available when I trained. Now, we did do endoscopic surgery on the brain. We would do a procedure called an endoscopic third ventriculostomy, 5 minutes, Dr. Santiago. So we learned how to do endoscopic surgery in training, but it was on the brain, not on the spine. And so I had some limited experience with endoscopic surgery from my training, but it was only on the brain. The spinal endoscopic procedures I learned from overseas, from the Koreans, and I learned from Dr. Anthony Young, who's now retired from Phoenix, and I learned from a German neurosurgeon, and I learned from an English neurosurgeon. So there were not many people in the world, but these were the very best at the time. This was 15 years ago. These guys were the very best endoscopic spine surgeons in the world. And there was a meeting in Hawaii, and I went there and I learned more, and then I followed up and I did a lot of training with Dr. Young, Anthony Young in Phoenix. So I learned the basics of this technique from doctors that had been doing it before me, and they were the pioneers, and they were great surgeons, and they were visionaries. Sang-Ho Lee, Dr. Gun from Korea, Dr. Sang-Ho Lee at Woodydal Hospital trained me. And then I came back to the States, and I started performing these surgeries back in 2006. And like I said, this was not taught to me in my residency program, even though I went to one of the top 2 or 3 residency programs in neurosurgery in the world. So it just shows you that if you want to be on the top of what you do, you have to stay open-minded, and you have to pursue learning constantly. Never stop learning. Never stop looking to see if there's something better. than what you're doing. And I always am evaluating new technology that comes out to see, is it better than what I'm doing? And if it's better, then I learn it and I master it and I give it to my patients as an option. So for those of you who don't know me, I'm not doing these surgeries because this is all I know how to do. I'm doing these surgeries because this is the best available in the world today for these problems. And I can do any surgery on the spine, any surgery. And I've been trained to do any surgery. I'm capable of doing any surgery. I choose, and my patients choose to do this surgery because this is the safest and most effective surgery in the world for a herniated disc in the neck or back. All right. I told you 5 minutes, 4 minutes ago. I want to stick to my word. There's a bone spur right there, but it's not pushing on the nerve. It's not bothering anybody. We're leaving it alone. There's another nerve right here in the foramen. You see it, the white thing right there? That's the nerve root. The dorsal root ganglion is right there. So this herniation was just below it. That, again, that bone spur, we're going to leave it alone because it's just going to cause bleeding. You see the bleeding coming from the bone spur? I was telling you about it earlier. They do bleed. So we leave them alone unless we have to take them out. Let's show the audience some of the herniation that we took out. Nice job, everyone. Dr. Santiago, what can I say? Masterful. Masterful. That's passion. Oh, before you do that, let me. Doctors that are good doctors because they're passionate about what they do. There's no other explanation. And if the doctor doesn't care, they're not passionate, they won't be a good doctor. All right, let's look at some of the pieces of herniation we took out. Sean, you want to bring the camera in?
Yes, we see them.
All right, so these, we didn't get all the herniations because a lot of it leaked out into this bag down there, but we saved a few, you know, just for memorabilia sake, right? All right. Let me show you the incision. Move your hand, please. This is the whole surgery was done through this incision right there. Okay? Just to give you an idea, that's 7 millimeters. It's tiny. This patient will go home in about an hour, and they'll be recovered in an hour. Okay? And this is the scope that we use with a camera, light source, irrigation. All right. Nice work, everybody. I'll come answer questions. So, audience, if you have questions about this surgery or anything related to the spine, go ahead and type it up and I'll do my best to answer it for you. I'm Dr. Deukmedjian, and if you get a chance, download the, I'm throwing this Raytech off, download the Deuk Spine Institute app from your app store. It's free and it has lots of good information. It has learning resources. You could also submit an MRI for review. You can see live streaming, and in the future we're building in the ability for people using our Deuk Spine Institute app to get a consultation with one of our doctors. Okay? So also, if you're on Facebook, check out the Spine Surgery Support Group. Spine Surgery Support Group, that is the Deuk Spine Institute Facebook group. It is free. It's open to anybody that wants to join. We just ask you not to try to advertise, and we'll just keep it as a dialogue and interesting things related to spine. You don't have to be a surgery patient to go. It's really just for information purposes and education. Okay, our next case, like I say, will be a 3-level Deuk Laser Disc Repair. But before that, I'll come and talk to you all and answer some questions. So start typing your questions up.
That was probably one of the things I noticed right away, was that like I had some control again, which was kind of cool. You know, you still have that sort of, your brain's relearning where things are again. So now that you're back to getting healthy, it's starting to come back. You're starting to feel like you're able to play. But yeah, I'll play. This song is called Oscar the Grouch Goes to the Movies. So yeah, we're a pretty musical family here. We play a lot of shows. We're in a band called Positive Chaos, and this is my bass. Picked it up a little while ago. We use it for acoustic shows. This is actually our guitarist's acoustic guitar. He actually just moved down here from Connecticut, so it's kind of cool having him down. This is our violinist and my fiance's violin, who has been in the band with us for a bunch of years now, and she's having some fun with that. This here's my acoustic guitar, which we'll be hanging out with later. And then this is our drummer's bassist of all things. So yeah, that's that guy. And a couple months ago, it'd be pretty much impossible to pick this guy up off the wall without some pain. So it's kind of cool that I'm able to start doing that again. From here. And I'm waiting for you. So that was cool. Like at this point, I wouldn't have been able to do this, I don't know, a month ago. And now I'm able to play guitar again. So it's kind of nice, it's getting back. And getting the band Positive Chaos back together is going to be pretty fun, and we're really looking forward to it. Thanks, Dr. Deuk. And we know this is the way to live, and you keep on calling back. Yeah, so my name is Dave. Last year I was in an auto accident. It was August. T-bone accident in the area. Suffered some neck injuries. Basically kind of spent some months just kind of dealing with it, then decided to talk to a chiropractor, started looking at it. From there, I did the epidural injections. Those were pretty successful. I was feeling a little better. And then woke up one day early, I think it was March, and I was agony. I couldn't move, couldn't lift my arm, aggravating the bottoms of my fingers, like everything hurt from the base of my skull down to all the way into the very base of my pinky. So it was kind of tough. Like, you know, everything that you did is now different. Like everything hurts, and it, you know, makes you irritable. It's like this like burning, stinging pain. So you kind of spend a lot of time like going around things. You spend a lot of time like tiptoeing through what you can and can't do. So I decided it was time to see somebody about it. So I went and found Dr. Deukmedjian. You know, you spend a lot of time going to different doctors' offices for something like this because you don't really know. You're looking for something to fix you. So I actually found Dr. Deukmedjian online. Like it wasn't like a referral sort of deal. So I go into the office and it's bright, which is different. A lot of doctors' offices are dark and they're kind of scary. So you go in and everybody's pretty happy. You're like, okay, this is a change. And you know, you talk to the staff there and they're excited to see you. Not only that, but they booked me the day after. Like I called them and they had a spot for me the next day. That was huge. So, you know, you go in there and you're talking to them and they're exuding this like sort of air that things are going to be okay. And they send you in, and I met with Dr. Deukmedjian's assistant, Luis, who's a great guy. He started setting me up, and he's going through the x-rays and kind of saying like, hey, listen, this is what you got going on. Dr. Deukmedjian's going to come in and explain it further to you. So Dr. Deukmedjian comes in, and he's got an air of confidence about him. You feel better when he's talked to this guy, and I remember him saying like, you know, you're in trouble. You have some issues here. But as he left, he was like, but we're going to patch you up. And that was the first time that I didn't feel fear in like 3 months. It was the first time that you felt good. You felt like, we're going to be okay. We're getting back to being okay. And that was a huge thing. Like this confidence that he had, this swagger that he had, where he came in and he was like, we're going to patch you up. And that was it. And it was like, all right, that's huge. Like that was a huge feeling. Yeah, when I woke up in surgery, I noticed that it felt like a garden hose had unraveled in my arm. Like I could feel things again, like it wasn't this like wrapped up tight pain. Like yeah, there's obviously surgical pain involved there, but it's, you know, you feel instantly better than you were. And it's kind of this, it's no longer like shooting down into your arms, it just feels like things are starting to heal, like things are back in the order that they should be. They're back kind of feeling the way that they should. So, and that was something I noticed that day. Like, you know, you're a little groggy from the medicine and all that stuff, but at the same time, you feel better, like instantly. if you have neck pain, like, or back pain, anything spinal, like, these are the guys to talk to. These are the best in the business. Like, this is what they do. And yeah, I'd highly recommend them. I would recommend them friends, family, strangers, absolutely. Like, yeah, I would highly recommend Dr. Deukmedjian. That's the end of it right there. So, definitely. Since the surgery out with Dr. Deuk, I'm able to get back to what I love to do. And that's the best part of it. Like, Dr. Deuk set me on the path to getting back to doing what I love. So that's huge. And that's awesome. My time, ooh, and I'm waiting for you. Thanks, Dr. Deuk.
Wow.
Cool.
That's amazing.
Thanks.
This is Dr. Deukmedjian, and just wrapping up our Deuk Laser Disc Repair, left side L34, L45. Why did this patient have surgery? They had herniated discs, degenerated disc at L34, L45 with back pain and left leg pain called sciatica. What other surgery could have been done? We could have done a fusion. We could have opened her back up. We could have taken all the bone out and unpinched the nerves and put in cages, screws, and rods. We do those surgeries here as well, and that surgery just takes a lot longer with the fusion to recover. It's a lot more pain. Patients are on narcotic opioid painkillers for months recovering from a fusion. Whereas with the laser surgery that was done instead, she won't be on any narcotics. She'll be taking Tylenol and muscle relaxer as needed, and the pain should be gone from the surgery within 2 days. Whereas with the fusion surgery, the pain is going to be there for 2 to 3 months, and it's much more debilitating, much more risky of complications happening, more blood loss, more chance for infection. So fusions, bad, barbaric, old-fashioned, out of vogue. Deuk Laser Disc Repair, endoscopic laser surgery, new, advanced, safer, better results, less risk. Believe it or not, 14 years of Deuk Laser Disc Repair, over 1,100 surgeries, 0 complications to date. There is no endoscopic surgery in the world, there's no open surgery in the world that has 0 complications except for the Deuk Laser Disc Repair. It's an incredible surgery for people who have herniated discs and are suffering with pain. All right, well, we've said everything we need to say for this, and we don't have any questions. Our audience knows everything. Oh, one question popped up. All right, go ahead, Sean.
All right, we have a viewer that submitted this question to the Duke Spine Institute app. They are wondering, I was diagnosed with compressive myelomania. I'm scheduled to have a 3-level ACDF, C4-5 through C6-7. Will the fusion stop the softening of the spine from progressing or simply stabilize it?
Well, hello. Thank you for asking that question. As a matter of fact, I thought I saw that asked the other day, and I'm glad you asked the question. All right. Well, let's talk a little bit about what's going on here. I'm going to give a little bit of history, anatomy, etc., to better understand for the rest of the audience. And just so you know, I can answer your question very easily with 1 or 2 words or sentences, but I'd like to bring the rest of the audience in. And I like to take questions from people, and instead of just directly answering them, I like to educate people so that everybody watching, everybody listening, which could be thousands of people who are watching and listening over the various platforms we're broadcasting live, I like everyone to get something out of this question and the answer. So this is a person who's saying that they have a problem with their neck. And the problem is specifically with the spine. And specifically in the spine, it involves 3 discs, 3 areas, one on top of the other, in a row, where there's pressure on the spinal cord, which runs behind the discs in the neck. And the pressure on the spinal cord has caused damage to the spinal cord. So just to be clear, so everybody understands, the way that your brain, which is your consciousness, is in your brain, the way that your brain or consciousness interacts with the rest of your body from your neck down is through a cable. This is a biological, organic cable called the spinal cord. This cable has fibers running through it, just like fibers in a fiber optic cable. They transmit information, these little fibers do. There's a name for the fibers inside the cable. They're called nerves, specifically axons. That's the part of the nerve that moves down the cable. It's a long, skinny cell, or part of a cell, that transmits electrical impulses. And just like a circuit board or a electrical circuit, there's a movement of electrical information down the axons in the middle of this cord. The cord itself being the spinal cord. So the brain gets information from the body and transmits information back to the body It controls muscles, tells you how to pick things up, how to write, how to play the piano, how to run, play soccer, by signals passing through the spinal cord. Also, if you're feeling something on your skin, an itch or a feeling, a pain, it's all transmitted through your spinal cord to your brain, from the body up through the spinal cord to the brain. The spinal cord is about the width of a pinky. So look at your hand, look at your pinky. That is about how wide your spinal cord is. And it runs from the brain down to the body. Now it passes in the middle of the neck, specifically in the middle of the spine. And it's enclosed in a bony part of the spine called the spinal canal. And in the front part of the spinal canal you have bones and discs. And those bones and discs provide support but allow movement. Over time, people get injuries to those discs, and the discs bulge either forward, sideways, or backwards when they bulge out. If they bulge out forward or sideways, there's no problem. But when they bulge out backwards, those disc herniations can push on the spinal cord because the spinal cord is behind the disc. So if you have disc herniations or even bone spurs that are pushing on the spinal cord from injured discs, they can cause damage to the spinal cord. And that damage to the spinal cord is called myelomalacia. Malacia means softening. Myelo means white. So it's a white softening or softening of the spinal cord. Now, by the way, it doesn't matter what color your skin is, black, white, yellow, Mexican, Chinese. We all have a white spinal cord. Everybody does. And that white color is due to a fatty substance in the spinal cord called myelin. And that's getting a little bit further than we need to, but the myelin, the fatty substance, is what's damaged along with the axons, which are the cells that transmit the electrical impulses. So when you have damage to the myelin or fatty substance wrapped around the axons to insulate and protect them, that damage is manifested on an MRI scan as something called myelomalacia, or loss of white matter within the spinal cord. Anyway, the question was, after surgery, I'm having an ACDF. After the surgery, will those myelomalacia changes stabilize, or will they get worse? And the answer is, the purpose of the surgery is to unpinch the spinal cord so that the damage stops. So the myelomalacia changes should stop getting worse. Will they get better? Nobody knows. There's been studies about this where they looked at patients with myelomalacia from compression, like this person has, and some of the patients get an improvement, some don't. All right, and it's independent of whether they get symptom improvement. So there's really no relationship. What I do agree with, though, is that you need surgery. I'm not sure an anterior cervical discectomy infusion is the best surgery for you. I would love to see your MRI and see if the laser surgery would be a better option. Laser surgery that we perform at Duke Spine Institute is done without fusion, without metal. You don't need to have a fusion to fix the problem. You don't need metal to fix the problem. What you need is something called a decompression, and that's the first thing the surgeon should do. If your surgeon is not doing a decompression with your fusion, you need to leave that surgeon and get a better surgeon. The decompression is the most important part of your surgery. Decompression means to take the pressure off of something. Your spinal cord needs the pressure taken off of it. The problem is that half the spine surgeons out there in the world don't do a decompression because it's too scary for them. They don't know how to do it. They're afraid to do it because they don't want to make you paralyzed during the surgery. But that's not the surgeon you want fixing your neck. Trust me. You need a decompression. And the only way to get a decompression is to surgically decompress the spinal cord. So your surgeon has to be willing to do that. They have to be willing to take the risk and not panic, and they have to do what's right for the patient. There's lots of surgeons that want to operate, but they don't want to put their own neck in the noose and possibly injure you, so you sue them. So they're so afraid of lawsuits that they won't do what's right for the patient by decompressing the spinal cord. I'm going off on this because this is real and it happens every day. It happens all the time and around the world. Neurosurgeons, I think, are better trained to decompress the spinal cord. So the first question you should ask is, do I have a neurosurgeon or orthopedic surgeon? If you have an orthopedic surgeon, there's about a 95% chance they're not going to decompress your spinal cord. They're just going to fuse you, which you don't want just a fusion because you won't get better. You see, the only way you're actually going to get better is if you have that decompression done. And a neurosurgeon is really the only surgeon in the world qualified to do that. So I hope you have a neurosurgeon. And if you do, even having a neurosurgeon doesn't guarantee they're going to do the job right. Most neurosurgeons don't. So I would say if you have an orthopedic surgeon, there's a 1% chance they're going to do the job right and you're going to get better. If you have a neurosurgeon, there's a 50-50 chance they're going to do the job right and you're going to get better. So odds are definitely not in your favor no matter where you go. And the reason is, unfortunately, there's no standard for treatment of what we call a decompression. Yeah. I hope you have a good surgeon. If you do, it sounds like you're having the right surgery as long as it's a decompression and a fusion. And I think a better surgery would be the Deuk Laser Disc Repair. But maybe it's too late for that now. All right, well, thanks for asking the question. I hope I was able to answer it for you. It was a little bit long-winded, but I think I did allow the answer to have the opportunity for other people to get engaged and learn something. All right, we'll be starting our next surgery in about 20 minutes. So take a break, go pop some popcorn, refill your soda, and come on back.